Hi, welcome to Conversations in Interventional Cardiology. My name is Andrew Goldsweig. I'm the director of the Cardiac Cath Lab at Bay State Medical Center in Springfield, Massachusetts, and an associate editor of SCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent SCAI and our editor-in-chief, Dr. Alexandra Lansky. We're here today to discuss an important paper recently published in SCAI entitled Comparison of Different PCI Strategies for Coronary DES in-stent restenosis, a Bayesian network meta-analysis of randomized and non-randomized studies. The initial presentation of these data was selected as a top abstract at the SCAI 2024 scientific sessions in Long Beach, California. I'm joined today by an esteemed panel of experts and thought leaders in the field of percutaneous coronary intervention. Dr. Prakash Oli, an internal medicine resident at Mount Sinai Hospital in Chicago, is the first author of the paper we'll be discussing today. Dr. Evan Shlofmitz is an interventional cardiologist and director of intravascular imaging at St. Francis Hospital in Roswell, New York. Team, thank you so very much for joining today. It's great to have you. Look forward to discussing this important paper. I'm going to direct a first question to Dr. Oli. First, congratulations on this publication and this excellent contribution to the literature. This paper really compares multiple possible treatment strategies for in-stent restenosis, which continues to plague PCI. Could you take us through the most important points and the most important findings? I know that you prepared some slides to share.
Thank you very much for this invitation. I'm honored to have this opportunity to present our paper on behalf of all the co-authors. Our paper was, like you mentioned, was presented as a top abstract at last SCAI conference at Long Beach, California by one of the authors. So briefly talking about the rationale of our paper, percutaneous coronary intervention with coronary stent placement is a common cardiac procedure that is performed throughout the globe, as well as in the United States. Like in 2017, almost 640,000 PCI procedures were performed in the United States. And the number of the PCI procedures performed is increasing each year. About like 5 to 10% of the patients who receive coronary stent placement are at the risk of developing coronary in-stent restenosis during their post-PCI lifetime. To encounter this issue, there has been significant advancement in the technique of PCI as well as the type of the stent used for PCI, like drug-eluting stent itself. But even with DES-based PCI, in-stent restenosis and target lesion revascularization still occur at 1 to 2% annually. And there are a significant number of different PCI-based strategies to manage coronary in-stent restenosis, like balloon angioplasty, DCB, drug-eluting stent, rotational atherectomy, and so on. Also, there are significant differences in the recommendation from American Heart Association and European Society of Cardiology regarding the management of coronary in-stent restenosis. But they do not mention about any differences in the management of coronary drug-eluting stent in-stent restenosis and coronary bare metal stent in-stent restenosis, despite of significant differences in the underlying mechanism of these type of in-stent restenosis for the different types of stent used. So there are a growing number of evidences showing the different clinical safety and efficacy profile for different types of PCI-based interventions for the management of coronary DES in-stent restenosis. In this scenario, we perform this Bayesian network meta-analysis with BoxNet package in R. Plain balloon angioplasty was used as a comparator intervention for the analysis. Target lesion revascularization was primary outcome of interest for our analysis, whereas major adverse cardiac event, target lesion failure, target vessel revascularization, all-cause death, cardiac death, stent thrombosis, and recurrent myocardial infarction were secondary outcome. From initial database search, we found 1,202 relevant studies, among which only 30 studies with 8,016 patients with coronary DES in-stent restenosis were eligible and included for the analysis. Among 30 included studies, 15 were randomized controlled trials and remaining 15 were non-randomized studies. Figure A to E show the network meta-analysis plot for target lesion revascularization, MACE, myocardial infarction, all-cause death, and stent thrombosis, respectively. And these network meta-analysis plot shows that all the interventions in each outcome were interconnected with each other. And to determine which intervention is better compared to other intervention, for each outcome, we calculated SUCRA value. Like high SUCRA value for an intervention for an outcome like target lesion revascularization represent lower the chances of occurrence of that outcome for that intervention. And from our analysis, we found that for primary outcome, that is target lesion revascularization, particularly paclitaxel eluting stent was superior compared to other interventions. Whereas regarding secondary outcome, drug-coated balloon, specifically paclitaxel-coated balloon based in PCI intervention was superior compared to other intervention in regard to major adverse cardiac event, all-cause death, and cardiac death. Similarly, sirolimus-coated balloon-based intervention was superior compared to other interventions in regarding target lesion failure, stent thrombosis, and recurrent myocardial infarction. But unfortunately, we did not find any form of balloon angioplasty-based PCI interventions were superior compared to DCB or DES-based PCI interventions for all outcome of interest of our analysis, except for target vessel revascularization. Here we can see that leak plot heat map for target lesion revascularization and MACE showed that all DCB and DES-based PCI interventions, including specific subtype of them, might have significantly lower occurrence of these outcomes compared to plain balloon angioplasty. Similar result was found in the NMA forest plot for target lesion revascularization and MACE while compared against plain balloon angioplasty. Based on this Bayesian network meta-analysis, drug-coated balloon-based PCI, especially paclitaxel-coated balloon and sirolimus-coated balloon, and drug-eluting stent-based PCI, specifically, if available, paclitaxel-eluting stent can be considered for treatment and management of the coronary drug stent in-stent restenosis to achieve most of the clinical benefit and in regard of clinical efficacy and safety for target lesion revascularization, MACE, and its individual component. But however, this analysis is limited by the scarce number of the studies comparing direct comparison of different interventions included in this analysis. But we hope in future, larger randomized control trials comparing these interventions for coronary DES in-stent restenosis may shed light in this area. Thank you.
Terrific. Well, thank you very much. That's very exciting. There are a lot of different tools to be used for in-stent restenosis, and I really appreciate the rundown there in terms of their strengths and weaknesses. I want to turn to Dr. Shlofmitz here, talk about some of these tools, and particularly kind of run through some of the hot topics in in-stent restenosis and get your thoughts. So first, let's talk about intravascular imaging, right? That's definitely an area of your tremendous expertise. In in-stent restenosis, is intravascular imaging necessary? Is there an advantage to IVUS or OCT?
All right. Well, thanks so much. First of all, excellent presentation. And, I think such an important question because, when it comes to ISR, it's not all just one single entity. And it really is dependent on the intravascular imaging to identify what that mechanism of disease. How many layers of stent? Is it stent under expansion? Is it new atherosclerosis? Endomal hyperplasia, and whether or not it's calcified. And that really determines then what the optimal treatment strategy is. So, that's exactly what, the multi-society cardiac guidelines support, basically as a class 2A for in-stent restenosis, to consider IVUS or OCT to identify the mechanism of disease. And I agree with the guidelines there that it's either IVUS or OCT. The key is that you're using intravascular imaging to identify what that mechanism is. There are different advantages and disadvantages of the two technologies. Oftentimes, there's an advantage of OCT just because of the higher resolution in the setting of in-stent restenosis. But the reality is, if you're using intravascular imaging, you're going to be significant steps ahead of just angiographic-based decision. And even with intravascular ultrasound, you can often determine the exact mechanism of disease and let it guide your therapy.
Fair enough. Okay, so we do our intravascular imaging, and then the next decision tree, I guess in my mind, is plaque modification, right? Do we need to modify plaque with any devices before we start deploying these definitive tools, be they drug-coated balloons, plain old balloon angioplasties, or drug-eluting stents? So let me ask you, intravascular lithotripsy, laser atherectomy, these are frequently cited tools. What do you do next?
What to do next, exactly what you said, is you modify the plaque. And that's the key thing is, Dr. Ali showed really is what supports, current practice, that DCBs, DES, we know have an advantage to balloon angioplasty alone. But as you so eloquently mentioned, is that that's a definitive therapy. But before you get to the DCB or another layer of stent, you need to modify what brought the patient there in the first place. And, one that's identifying the mechanism of disease through the imaging. And then I like to custom tailor it based on the mechanism, what tools are necessary. But the whole goal is that we increase the size of the lumen area. You enlarge that stent and enlarge the lumen area so that when you apply whatever that definitive therapy is, be it a drug-coated balloon or a drug-eluting stent, that you'll have a more durable long-term result. So, I think that the techniques you mentioned, IVL, laser, are definitely part of a modern algorithm for treating in-stent restenosis. If there's calcific disease, both within the stent or extra stent causing underexpansion, we know that IVL is an effective therapy. We know that laser has a role, particularly with tissue inside of the stent. But it's also specialty balloons, I think, have a really important role here. You don't always need this adjunctive atherectomy or lithotripsy. Very often, it's just specialty balloons, scoring, cutting balloons are effective at modifying the plaque, particularly with neointimal hyperplasia. So for me, I don't believe there's a one size fits all. The imaging will show you if it's calcified, then just like you do, just following the SCAI algorithm for treating calcific plaque, it's pretty similar if there's a stent there. Once you identify the type of calcium, you just go down the calcium algorithm. If the imaging shows you it's all soft tissue, then typically just the specialty balloons, and sometimes with laser we often are using. If it's underexpanded, typically it's underexpanded just because there's calcium beyond the stent, and it's just addressing that. And then once you go back, confirm you have a good area with the imaging, then you're ready for your definitive therapy. Agent, most recently, the Agent IDE randomized trial showed, in a really favorable way, that the benefit of using a drug-coated balloon compared with that balloon angioplasty result, completely aligned with the current presentation. And then, of course, there's often a role for an additional layer of stents. Dr. Ziad Ali had shown with the Lumen 4 sub-analysis just the optimal results associated with contemporary drug-eluting stents. So, I think all of the above are definitely part of the practice of modifying plaque and treating in-stent restenosis, but it's all about, you want to enlarge that area, and aggressive plaque modification. Now, I always say that the agent balloon or any drug-coated balloon should never be your first balloon that you're using in that procedure. You really want to make sure you have good expansion.
It's a great summary. Obviously, a lot more choices available now in terms of tools than there were even just a couple of years ago, even just a couple of months ago, thanks to the FDA approval for in-stent restenosis of the agent balloon, although the price point makes it challenging, I think, at many institutions to get access, especially in light of the present level of reimbursement. Let me turn the table back to you, Dr. Ali. If I develop in-stent restenosis, definitive therapy, it sounds like I don't want balloon angioplasty. Dr. Shlofmitz is going to prep my vessel with laser atherectomy or scoring balloons or cutting balloons. But then as a definitive therapy, could you comment on what you found regarding drug-eluting stent, a second layer of stent versus drug-coated balloon?
In this regard, like depending on the patient characteristic and the characteristic of the lesion, like we found during the imaging whether like we use OCT or intravascular ultrasound for lesion characteristic, and the patient characteristic like whether there is like risk for the mortality or risk for like stent thrombosis again, and thus having the recurrent myocardial infarction. Depending on this risk and benefit, what we expect, which outcome we want, we can either like prefer for the drug-eluting stent, particularly pacted axle-eluting stent, but stent on stent has like higher chances of thrombosis of the stent again from like underlying pre-existing precursor of the lesion, like neointimal hyperplasia or calcification. That was the etiology for in-stent restenosis of the previous stent. So in this case, drug-coated balloon could be a potential option for such patient. We already have like a stent placed previously and they have like a repeat stenting placement. But if a patient has like a stent placed previously and that was the first stent and they are presented as an in-stent restenosis case for the first time, then we can like go for repeat stenting if we want to prevent the target lesion revascularization in the coming future. But if we want to like get mortality benefit, then we can go for the like a drug-coated balloon, like pacted axle-coated balloon or sirolimus-coated balloon, like agent IDE trial, so that like a drug-coated balloon were like more beneficial in regard of mortality benefit for patients who have like in-stent restenosis. But there is like a gray area still, and lots of the like trials are still going on to find out which modality of intervention is better in regard of all the clinical efficacy and safety outcome.
Great. Yeah, agreed. The data are still very much evolving, right? The Cordis solution sirolimus balloon is enrolling patients in a pivotal trial for in-stent restenosis, as well as a pivotal trial for de novo coronary stenosis. So it's not just about ISR. De novo stenosis is evolving too. Well, that's our time for today. So thank you very much, Dr. Ali, Dr. Shlofmitz. We are thrilled to include this important paper in the December 2024 issue of JSCAI and to share this discussion with our incredible panel. Please follow JSCAI and submit your own work to JSCAI. JSCAI is the official journal of the Society for Cardiovascular Angiography and Interventions. And you can find us online at jscai.org, jscai.org, and on X at MyJSCAI. Thank you very much.